Good afternoon, everyone. Thank you for joining us today. We are lucky. We have Sarah Brinkman from Stratus Health, who is part of the Rural Quality Improvement Technical Assistance Group. She's going to be presenting over best practices and ideas to improving emergency department throughput. So that would be our outpatient 18 and outpatient 22 measures. We're a small group. Again, we'll be recording this to put on YouTube later. But if you have any questions, please feel free to unmute yourself or put something in the chat. I'll be watching the chat. And with that said, Sarah, I'll turn it over to you.
Excellent. Thank you. Yeah, I'm just going to get my bearings here for a moment. Okay. Well, debating turning my video on. Usually I have my video on. I'll go ahead and do that. Okay, so thank you for having me today. I am excited to talk to you all and to hear from you. So really looking for your input as we talk about this. What we know about best practices for improving emergency department throughput is from pre-COVID times. So we're also interested in hearing about what your current challenges are related to ED throughput, and recognizing that while we can bring forward some suggestions and best practices for you to consider, there's a lot of knowledge in the room. And so some of you may have heard me present before. It's been a while since I've been on an Oklahoma Critical Access Hospital webinar, but I definitely have done them in the past. And so if you've seen me present before, you know I'm a really informal presenter. I love for this to be interactive. Please feel free to turn your cameras on. Please unmute and interrupt me if something I say doesn't make sense, if it doesn't align with your understanding, if you want to cheer something that you've used or give examples, and feel free to use the chat. You know, Laura will be helping me kind of manage that if there are things that come in so that we can talk as we go. So we have plenty of time through this presentation to have it be interactive. I don't have it chock full of just didactic, so please do engage. A little bit about where I'm coming to you from. Stratus Health is my employer. We are an independent nonprofit based in Minnesota. We just celebrated our 50th year in 2021. So we are not a research center. We're not a policy shop. We're not in the field of providing direct service, but we really work at the intersection of research, policy, and practice with a focus on leading collaboration and innovation to promote healthcare quality and safety. And we have a particularly long history of working with rural providers, including critical access hospitals and the FLEX programs nationally. And so today I'm here in our capacity as the Rural Quality Improvement Technical Assistance Center. So this is a cooperative agreement with funding that we hold with the Federal Office of Rural Health Policy under the Health Resources and Services Administration. So HRSA's FORHP, Federal Office of Rural Health Policy, is the same entity that funds your state flex program. So that's how you get to work with Laura and Corey and others at the Oklahoma State Flex program. And that is how we get funded to then be able to support the state flex programs and the critical access hospitals that they work with. We work in the same kind of space as Stratus does generally on improving health quality and health outcomes, and specifically focus then on our rural communities through those that are beneficiaries of FORHP's quality initiatives. Specifically today, we're going to talk about the FLEX program, the Medicare Rural Hospital Flexibility Program, and within that, the Medicare Beneficiary Quality Improvement Project, or MBQIP. So our objectives for today, we're going to review the 2 ED throughput measures that are part of MBQIP and explore and share some best practices and suggested strategies related to those measures. And then I'm really hoping that we can engage in an interactive discussion about current challenges, including the impact of COVID-19 on your ED throughput times. So we'll jump right in to talk about the measures themselves. When we look at the MBQIP core measures, there are 4 domains. These should look familiar to most of you. I'm assuming that you're probably intimately familiar with some of these measures. So there's the patient safety and inpatient domain, patient engagement domain, care transitions, and then outpatient is everything that happens in the emergency department. Specifically today, we're going to be focusing on those 2 ED throughput measures, and we'll dive into them a little bit more deeply here in a moment. Those two measures are both reported to CMS through their hospital quality reporting portal. And so the OP18 is a CMS output measure that is submitted via CART or vendor tool, which means it's chart abstracted. And then OP22 is a measure that's submitted via HARP and into the HQR. It's an administrative measure, and so it's not chart abstracted. And then this infographic hopefully is, some of you will recognize this. This is a way that we try to convey all the various ways that the measures that are part of the core set for MBQIP are collected, reported, and get to where they're going. So hospital quality reporting is the mechanism for reporting the measures through CMS. The National Healthcare Safety Network, in the orange there, NHSN, is the mechanism for reporting measures through the CDC. And then your emergency department transfer communication measure is reported through your state flex program. So today the measures we're talking about are both reported to CMS through HQR. The basics of OP18, the actual measure title itself is the median time from ED arrival to ED departure for discharged ED patients. We say ED a lot in that one. The purpose for OP18 is really looking at the importance that reducing time patients remain in the emergency department can improve access to treatment and increase quality of care. So obviously, the longer you have patients in the emergency department, if you have a busy ED, the longer you have patients waiting to be seen. And that's directly going to impact what we talk about when we look at OP22 as well. We know that when EDs are overwhelmed, their ability to respond to community emergencies and disasters can be compromised. So we want to get patients through the emergency department as quickly as possible, with the most efficient and effective care as possible, obviously being the caveat there. We also know that ED, that patient experience in the emergency department is hugely important. And so if you have ever been a patient in the emergency department, you know that it feels like you're there forever, as opposed to when you are a staff in a busy emergency department, it feels like time's flying by because there's a lot going on and you're just trying to keep up. So those differing perspectives is an important part of this measure as well. This measure, as I mentioned earlier, it's chart abstracted and reported to hospital quality reporting, and it is done so quarterly. The basics for OP22, this is looking at how many patients left without being seen. And the goal here is, again, around reducing the time, the patient wait time in the emergency department in order to get patients seen as quickly as possible. And this is a huge benefit that critical access hospitals have in comparison to their tertiary counterparts. And we would encourage you, if you have high performance for patients left without being seen and ED throughput times in general, that you leverage that to promote the services that you have available at your facility. So again, we want to improve access to care, increase capability to provide treatment, reduce ambulance refusals and diversion, reduce rushed treatment environments, delays in medication administration, and patient suffering. This is an annual measure that is reported through administrative data and hospital tracking. Because patients are leaving without being seen, there isn't a chart to abstract from. It's important that you set up a mechanism for collecting that data to be able to report into that measure. So I'll talk through some high-level suggestions of best practices or resources that you can look to use for improving your ED throughput. And really, these two measures go hand in hand. You can imagine that as you're looking at reducing your ED throughput times, if patients are able to get through the emergency department faster, that means you have fewer folks waiting to be seen, which means that you're less likely to have patients leave without being seen. So some of these will go hand in hand together, and some of them will be more specific to one or the other measure. There's suggestions around forming a patient flow team. So this would be a multidisciplinary and departmental representation, recognizing that there are a lot of other departments that play into how long patients are in the emergency department. If you have imaging, if you have labs and so on, pharmacy consults and that type of thing, you want to make sure that you have a multidisciplinary team engaged in determining your emergency department flow, including your inpatient unit. Although patients who are admitted to the facility aren't included in this measure, they do then hold up the measures, right? So if you have patients sitting in the ED for a long time waiting to be admitted to the floor, that's going to cause backups in other parts of the emergency department. So having a multidisciplinary team that meets to talk about the flow in the emergency department. This should include day-to-day senior and technical leaders. So who's in charge from any given point in time in the day, to the senior leads in the emergency department and technical leaders in the emergency department. And important to also identify champions beyond those leaders. Who are folks who are really going to lead the cause? Whenever we talk about quality improvement initiatives, we always encourage you to look for the squeaky wheel, the person who's kind of the naysayer about a given project. Getting them on board from the beginning, having them buy into the process goes a long way towards getting the rest of the team engaged, as opposed to having them be on the outside of the project and not necessarily supportive, and maybe being that voice in people's ear to say that whatever the project is pushing for it's not doing it the right way. If they're engaged in the project, it's going to help you get things moving a lot faster. You want to be measuring performance. So looking at regulatory and accreditation data, mission-driven data, and rapid cycle change data. So there's various levels of data that you want to be looking at. And you want to be identifying and obviously testing your strategies. This is your basic quality improvement principles. And some of the tools that we think you'll find most useful related to that are around process mapping. When we're looking at patient flow, those process maps can be really helpful. What do we think is happening, or how is it supposed to happen versus what's actually happening, and identifying where those gaps are. So some good old-fashioned process mapping, if you're able to add some of the Lean Six Sigma concepts to that to really measure time and determine how long each step in the process typically takes. What are the outliers? Why does it take longer for some patients than other patients? And again, that's where that multidisciplinary and departmental representation is going to be hugely important. What does it look like to get a patient through the emergency department if they need labs or they need imaging versus if they don't? Those are important factors to consider. And basic change management processes, taking those into consideration. What's in it for me, for your staff, ensuring that they understand the goals and the aims of the initiative, and then sharing the results, good, bad, and different. You want to be sharing the results and keeping people abreast of how the project is going. All of these recommendations come from a resource from the Agency for Healthcare Research and Quality, AHRQ, and I'll send these slides to Laura after the session today. There's a link at the bottom of the slide that takes you out to a resource that they have specifically titled Improving Patient Flow and Reducing ED Crowding. Some alternative patient flows that you may want to consider in the emergency department if you aren't already, and often critical access hospitals have this again in the bag. It's one of the benefits of being a smaller facility. Being able to do nurse triage and registration at the bedside, that really helps with the left without being seen. If the moment that someone gets there, they're registered at the bedside, you've already averted the potential for them to leave without being seen. Having the provider and RN team provide evaluations upon arrival as possible, and then making sure that low acuity patients get evaluated upon arrival and discharged as soon as their registration is complete. If it's not appropriate for them to be in the emergency department, if they don't need to be there for long, sometimes it can feel like, well, they're low acuity, so we're not going to be as concerned about them. They can kind of fall to the bottom of the list, but actually if you can get them in and out of the facility faster, that's going to be a benefit to everyone involved. I mentioned this earlier. When we think about these throughput times, you're not measuring patient experience with these measures, but they definitely impact patient experience. So whether your facility is actively engaged in emergency department consumer assessment of healthcare providers and systems, the ED caps, or some other type of emergency department survey, you're very likely participating in HCAPS, the hospital consumer assessment of healthcare providers and systems, as part of MBQIP and SHIP. And what we know about patient experience is we silo our various units within the hospital. We think about things that happen in the emergency department, things that happen in inpatient, things that happen in the clinic. Patients do not think about healthcare in that way. They don't think about the inpatient floor as being separate from the emergency department or from the clinic, particularly when they might see the same provider in all three of those settings or the same nurse. So it's really important that we think about the impact that an emergency department experience can have on a patient when we're looking at even our HCAHPS results. So what does it look like for flow in the emergency department? And it could be that it was all part of the same experience, and it could be that it was completely separate. So one story that I always kind of like to tell is that I used to work in the patient experience department at a relatively large health system. And I was reviewing our patient experience results, the comments that came in from a set of the clinician and group, the CG caps, so what you would do in the ambulatory setting. And this particular patient had been seen she was being seen in the eye clinic. And so she was being seen by an ophthalmologist, and she was responding to the survey. And her comments were about an experience that she had in the urology clinic a month prior. But for her responding to the survey was an opportunity for her to speak about her entire experience. And if you've ever gone through the survey, I think if you read through it, you can skip through things relatively quickly. That particular health system that I was working at actually did the phone survey. So someone was reading her the script, and the script repeats over and over again. We're talking about this particular time that you were seen on this date in this clinic by this provider. They tell you that multiple times. And still at the end, when it came to giving feedback, she was reflecting on other experiences. So when we talk to patients about their experience in the inpatient unit, in the clinic, in the emergency department, everything that they're experiencing within our either large or small health system is going to come into play. So when it comes to patient experience in the emergency department related to throughput, communication is key. It's key in all aspects of our care delivery. We want to be setting expectations, under promising and over delivering. So if you think it's going to be 10 minutes before they get seen, maybe you tell them it's going to be 20 minutes so that you can get them in faster. And then that way, if you run into any snags, you've built in some wiggle room there. And then you want to provide updates. If it's going to take longer than you anticipated, letting them know. Recognizing that 10 minutes for a busy emergency department staff person goes by in the blink of an eye. And for someone who is in what they could perceive at least to be an emergency, and they're sitting in the waiting room of an emergency department, 10 minutes feels like a lifetime. Remove all references to the term waiting. So we call them waiting rooms, and then that reminds people that they're waiting. I think that this is a really compelling idea to think of your waiting rooms as reception areas instead of waiting rooms, and even remove the term waiting from any signs or things like that, that it's your emergency department reception area. So arranging the space in such a way that allows folks to have some privacy. If you're sitting in a busy emergency department, I don't know about any of you, I have young kids, and when one of them has been ill and I have to think about bringing them in, or if they get injured and I have to think about bringing them in, I always weigh it against, do I really want to bring a sick child to an emergency department waiting room where they could potentially be around a bunch of other people who are sick, but they aren't acute enough to get in right away? So thinking about, what does that look like for the patients? Is it one big space where everyone is exposed to one another, or can you arrange the space in such a way to make little alcoves for folks so it doesn't feel like they're all, so that they have their own space to wait? And then giving them things to occupy their time, having magazines, having toys for kids, having the TVs in different little alcoves if that's possible, things like that to ensure that they're not just sitting. And then patient and family feedback. Engage, if you have a patient and family advisory council, have you engage them in what an emergency department experience looks like. Reviewing your emergency department survey feedback, and then completing some follow-up calls post-discharge to patients who left without being seen. So when patients do present to the emergency department, are you capturing information so that if they leave before they're seen by a provider, you have a way to follow up with them and to ask them some questions? They're not going to fall into your ED caps or survey populations because they didn't actually get a chart. They weren't actually seen. So how are you following up with those patients and seeing what you could have done to help ensure that they didn't leave without being seen. Data collection and monitoring. These are some suggestions for points of data that you might be interested in collecting and sharing with your staff. Sharing the median patient time spent in the ED data with your emergencies department, the managers, staff, and providers. If you can do that on a daily basis or a weekly basis, that's really useful. Again, that perception is totally different for the staff versus the patient. So it can be really, really important to put that information in front of the staff. Implement a process for collecting the left without being seen measure. So you get that contact data and you have a way to actually administratively report the percentage of the patients who do leave without being seen. And then conducting regular patient record analysis to identify and understand trends. So when is it that patients are in the emergency department for longer than others? As I mentioned previously, are they patients who needed labs? Are they patients who needed imaging? Are they patients who needed a pharmacy consult or a dietary consult? Or what types of diagnoses were at play that for patients who either get through the emergency department quicker so that you can find out why that is and maybe be able to replicate it for other diagnosis groups, or that take longer so that you can try to figure out what the pain points are in that process and free up any backlogs or log jams that may be in the way. So I'm going to pause there and see what questions you have, and then I want to open it up to discussion around the challenges that your facilities might be experiencing right now related to emergency department throughput. I am going to stop my share so that folks can turn their cameras on if they like, and hopefully join in a discussion. Any questions, comments, or challenges that your facilities are experiencing that you'd be willing to share?
Sarah, this is Emily at O'Keene. We don't have, since we're so small, we don't have a registration at the bedside, so our nurses have to do that from when they come into the ER, and so that slows things down a little bit.
Sure. Yeah, so working with the resources that you have available and the teams that you have available. And so, Emily, what does staffing look like for your emergency department? Is the nurse, do you have LPNs, RNs?
We have LPNs and RNs. Our nurses who cover the ER also cover the floor. Okay. We don't have a set RN or nurse for the ER. They do both.
Sure.
So
and have they come up with any? Oh, I'm sorry. Go ahead.
That is a challenge for us.
Yeah. Have they come up with any creative strategies, or are there others on the call that have similar setups that have suggestions?
We really haven't had any. I mean, we haven't come up with any other strategies other than, we just don't have enough patient flow on the med-surg side and the ED to justify that. So.
Yeah, sure.
Although we do have our nurse aides who we try to train to do some of the registration. They have all our admission paperwork signed and things like that, and that helps a lot. Trying to remember that, but that's pretty much the strategy we have.
Yeah, no, that's great, Emily. So thank you for that. So those are the types of things that I think are helpful. If you have CNAs, if you've got folks on the floor who can maybe, swing into that role as ER triage, what does that look like, and how can you build their comfort and capacity to competence to do that if the volumes aren't large enough for them to be doing it on a routine basis, right? So that's always a little bit of a struggle, I think, regardless of service line in critical access hospitals, is do we have a sufficient enough volume for our team members to feel competent and confident in doing what we're asking them to do? So, giving them the opportunity to practice that, or ensuring that they're consistently used in that way, could potentially be a suggestion. Others? Thanks for that, Emily.
What about, we have on night shift, that's when the majority of our left without being seen, like if we have a code come in, which pretty much takes up all our staff, which is 2 RNs and a tech. And we have one X-ray tech, even lab helps. But that's when the majority of our left without being seen. Since I started this job, I can see that's where it's happening at. Any suggestions?
Yeah, I would open that up to the group. What are folks doing in those cases? What of the suggested strategies that we reviewed seem to make sense in that case, and what else have you tried? And does communication help or not? Does letting the patient know help or not? Paula, I see you unmuted. Go ahead.
So one strategy that we use is we have somebody designated that goes out and talks to people in the waiting room and the families, just to make them aware of what is going on on the actual floor. That does seem to help to people to understand what's going on, and it does seem to help with our left without being seen.
Thanks, Paula. Yeah, that kind of confirms an assumption that I would like to make about what would happen, which gets back to the kind of the communicating. So folks have a realistic expectation of how long it will be for them, without scaring them away, because they came to the emergency room thinking they needed to be seen, so they should be seen. And then also doing things to reduce the sense of waiting when they do need to be waiting. That kind of reception concept, and having things for them to do, and then providing updates as possible. So Paulo, you said you have someone who's kind of assigned to do that. I'm curious to know who takes on that role if you have a busy emergency department.
It usually is our house supervisor that takes on role, unless for some reason we don't have the house supervisor. If that's the case, then we do designate usually the charge nurse to do that if that person is available. So we have kind of a tiered system that we use as we go down. But in most cases, it's going to be our house supervisor.
Got it. Thanks, Paul.
Yes, we try to use our admissions. We have one at night also. They do very well in helping in that area also, but I don't know, it just seems like sometimes some of them can take extra long or whatever. I don't know what the deal is, but that's when they're leaving. Even being informed, and keeping up to date with it.
Yeah.
They're still getting upset and leaving. Yeah.
Yeah. Yeah. And we as individuals who have been in emergency departments can probably understand that, especially, depending on the circumstances too, right? Like if you have a child who has a fever, but it's not acute enough for them to be seen immediately, like, do you want to sit in the ER with a sick kiddo for 2 hours?
Right.
We know, and then you could potentially get into urgent care or whatever the case may be. So some of that. The other thing I think about left without being seen that actually isn't in the slides that we just reviewed, but I'm thinking of now and I've heard from others, is ensuring, and this is more of a not in the moment communication, but more about community education about what resources are available to them. So patients who leave without being seen feel that they need to be seen at the moment that they present, but then when presented with a wait, typically decide that it's not that urgent. So do folks understand what the emergency department is for and what their alternatives are? Are they able, do you have access? If you have clinics associated with your hospitals, is there same day access available for folks who would otherwise need to go to the emergency room? Are there minute clinics or urgent care available? And how is the community aware of what those resources are?
Okay, thank you.
Yeah, absolutely. Dora, I see that you unmuted. Did you have something to add?
Yes, we are actually a small facility as well. On nights, we have one RN, one LPN, or two LPNs, and one tech. Um, but we have a good rapport with our EMS crew. So if we get into a code situation, a lot of times we can call in EMS to help with that so that we free up one person who can take care of other ER walk-ins.
Oh, that's great. Yeah, leveraging all those relationships and resources you do have available. I'm curious, is anyone doing follow-up calls for the patients who leave without being seen?
No, ma'am, we're not.
Okay. If you were finding that that was a big issue for your facility, that would be another suggested strategy, is to start to gather feedback from those folks. Like what are the typical things that you don't even know necessarily what they're presenting with because they left without being seen. So is it tend to be that they're there because they have a low grade fever, or are they there because they need stitch? Like what is it that's bringing them to the emergency department, but then they're leaving before they're actually seen by a provider? It might be useful information if it does end up being an issue. Typically, critical access hospitals perform really well on that measure in comparison to their counterparts. But of course, every patient who comes in and leaves without being seen is a potential issue that we want to address. We don't want folks doing that. Has COVID-19 had an impact for any of you on these measures?
We have seen a little bit. I'm just waiting on testing wise, but I mean, not a lot to slow us down tremendously, I don't think.
Great, thanks, Emily.
Sarah,
I see
Mark,
Mark's. Oh, go ahead.
I was just going to say, Mark commented, Mark is in Alba, and he commented that COVID has slowed things down, but definitely increased their transfer time. Also, I would want to note that I've been out and about and doing some in-person site visits, and some folks have mentioned this, and that's kind of what led to our discussion of doing this webinar, was just the increase in left without being seen since COVID.
Yeah. And I personally, I don't have any research to back this up, but I think there's probably a couple of things at play there. If you're seeing an increase in your transfer times to get folks out of the emergency department and to a different facility, then you have a backup of folks who are waiting to be seen in the emergency department. And if I'm waiting to be seen in the emergency department, even if I came in not thinking that I have COVID, I don't want to sit in the emergency department waiting room with a bunch of people who might have COVID. So I think that probably increases rates of left without being seen, which is where the potential setup of your emergency department could be useful potentially in reducing that. So I know, for example, the ED that's closest to where I live has just these little alcoves set up with, when you're sitting, it's just you and the person you came in sitting in a little area, not out with the masses of folks who maybe are coughing and sneezing and what have you. And then obviously with an increase in COVID-19, again, this is a community education thing that I think the entire country has struggled with, is where are folks supposed to go if they think they have COVID-19? And unfortunately, a lot of them are coming to the emergency department, which isn't, they don't need emergency department care, but they don't know what to do when they think they have COVID-19 or they've gotten a positive test result and they're concerned. So they're showing up maybe unnecessarily in the emergency department. And so what are ways that we can stop that from happening to create those kind of log jams that happen in the system? Those are a few of the things that I've heard about, but curious if others have other examples of the ways COVID-19 has impacted your emergency department flow. Or do those things resonate or not?
This is Marcy at Prague Hospital. We did have a couple of months back last summer, July, August, when the COVID numbers were really high, and we had multiple patients that we literally couldn't get transferred out. We're having to sit in ED rooms for 12 to 24 hours. And so, of course, that backed up the entire flow of the ED. We did get to where some patients, I think, noted that they were leaving because they didn't want to wait in a waiting room with people coughing, et cetera. And so we did start seeing patients out in their cars. ED provider and ED nurse go out and see them in their vehicles to prevent, no tracking as far as like how that helped with preventing left without being seen. But it did kind of keep the flow going in the ED when we did have a backup due to delays in transfers.
Oh, that's super creative, Marcy. Thank you for that. So can you give us a little bit of insight into how that worked, depending on what they were coming for being? Were you just doing the initial registration in the car side instead of the bedside? Or how did that work?
Well, of course, we had the screening process at the ED entrance. And so that was mainly utilized for those that had, minor things that were being seen in the ED, a pediatric patient with a rash, something like that. And we would try and keep them separated if the parent or the patient themselves were agreeable to it, if they wanted to be seen out in the car. There were even some patients presenting with COVID symptoms that they didn't even want to come in the ED. So, but it was just basically based on providers' guidance on whether they thought they could be seen in the car, and if the patient or their parent, if it was a pediatric patient, if they were comfortable with it.
Wow, that's great. I haven't heard of that. I don't know if others have. I think that's a really creative solution. Paula, I appreciate the comment about the visitation policies. Yeah, I mean, no one wants to be in the ER, and definitely most people don't want to be there alone. So understanding that if patients couldn't have someone there with them, that they might leave without being seen, and that would have an impact. Again, I think that speaks to, do they really need to be in the emergency room? If they really needed emergency care, would it matter if they could have a visitor with them, as opposed to, is there a more appropriate place that they could potentially have been seen next day? If folks are leaving without being seen, do they need to come to the ER in the first place? Paula, do you happen to know, for those that left without being seen during the visitation, due to visitation issues, what types of things they were coming in for? I'm not sure if you're talking, Paula, but if you are, we can't hear you. Or Mark. Some were COVID, some were other reasons.
Sorry, I think it's easier if I just try to talk.
Yeah, go for it.
We had multiple reasons that the patients were coming in. We did have some that had COVID-related symptoms, and they wouldn't stay because they couldn't have a visitor come back, which was concerning. We did have some cases where the patients did come back later because they got sicker and decided that they need to be seen more than have a visitor. So, but it was multiple things. Some were, minor, but then there were others that were more concerning at that time.
Thanks for that, Paula.
Does that answer your question?
Oh, go ahead.
Does that answer your questions?
Yes, yeah, it does. I think, it's nice that visitation policies have kind of been reinstated, but I think it's also, this is a great time for us to reflect on what we've learned in case we need to, for COVID or for other future illnesses, need to put that restriction back in place. So what are the lessons learned from this that can help us to avoid those same issues in the future? And I don't have an answer to that. I'm just wondering if anyone else does, in terms of if the visitation policy was a driver for folks to leave without being seen, and then it turns out they really should have been seen, but they didn't want to wait or didn't want to be there without someone else. What can we do differently. So I know, for example, this is just, I know like in the hospital on the inpatient floors, one of the tools that we heard that that hospitals were using is using iPads and other types of tele equipment to engage loved ones when physicians were doing rounding, right? So if you were on the floor, if you were inpatient and you couldn't have your loved ones there or your caregivers there during rounds with the physician or with the nurses, that they just made it a standard part of their process to say, is there anyone that you would like to, FaceTime in, or doing it at a time when it worked for, to the extent possible, when it worked for someone's loved ones or caregivers to be available via phone or FaceTime or whatever the case might be. My experience of emergency departments is that they tend to feel like black holes for cell phone usage. That cell phones don't tend to work in the emergency departments that I've been in and I don't know if anyone has any insights into why that necessarily is, but what can patients be provided so that they don't feel disconnected, even if they are waiting in an emergency department by themselves? Is it a super sterile space? Do they, I'm just trying to think creatively about how we can encourage folks to stay, even if they can't have a visitor with them. Did anyone come up with any strategies during your visitor restriction time? Well, the validating thing is that you're all in good company. I don't think that anyone has a quick solution, but it's something that we'll continue to track on and look for. And if we come up with any suggestions, we will definitely. Oh, I love that, Holly, having them wait in their cars and keeping them updated so that while they're waiting, they can have a visitor with them. That's a great idea.
We got a cell phone number, just like Holly said, and would keep them updated.
It's almost like when you go to a restaurant and you get on the waiting list, right? We'll give your cell a call, or we'll jot you a text when we're ready to see you, so you don't have to sit in this waiting room with all these sick people by yourself. That's great. These are excellent ideas that you all are sharing. So please keep, if you have others to share things that you've done, please speak up. Or if you have any questions for me or Laura, you have a captive audience with us right now. And if there aren't any questions or additional comments, we certainly don't want to keep you longer than you need to be. So we can keep the conversation going, or we can wrap things up. I'll defer to all of you. Well, this has been super useful for me. I've jotted down a bunch of the ideas that you've shared. I think that this is really helpful for us to hear from the field, what's happening, what's working, what's not, and to think about how we can capture some lessons learned from our experience with COVID thus far. Hopefully we're on the tail end of it, but I don't know, numbers are on the rise in our community. And welcome feedback from you all. Laura knows how to be in touch with me. If you have any questions or additional suggestions, you can feel free to send them her way and she'll pass them along. I'll just volunteer her for that. And we will, like I said, we'll keep tabs on this too and be sharing things as we find other suggestions. So I thank you all very much for your time and attention and engagement. I appreciate the discussion. Laura, is there anything else that you wanted to cover today?
No, that is all. Thank you for doing our webinar. And just a reminder to folks on the call, Sarah's colleague, Laura Grangard, will be presenting on June 23rd. She's going to be going over the EDTC collection tool with us. And so I'll be sending out the reminder and the registration link for that as well. We recorded today's call. We're going to get it on YouTube as quickly as possible and also share Sarah's slides. And so, like Sarah mentioned, as you run across things that work, don't work, please send them our way. This was a great group, great discussion from everyone. So thank you all for your time, and everyone have a great day.